The next presentation is by Dr. Rapolu from Hyderabad in India.
Dr. Rapolu is our junior colleague who works in our own chain of hospital, and he's one of the most bright interventional cardiologists. The good thing about him is very persistent, never gives up. So he's just going up on his career, but he has a very bright future.
Thank you very much, sir. I would like to thank all the expert panel members and organizing committee of APVIC. So I'll start sharing my screen. So my presentation is I Saw Iron Man. Let's see who is he. So he's my case is a 53-year-old gentleman who had RTA with head injury and polytrauma 20 years back. He underwent neurosurgery and orthopedic surgeries subsequently in a peripheral center, where he developed sepsis during the course of hospitalization, which led to the infective endocarditis of tricuspid valve. So for the management of infective endocarditis, he has been shifted to a famous teaching institute in Hyderabad, Nizam's Institute of Medical Sciences at that time. And there, with the prolonged antibiotic treatment, they managed his infective endocarditis, but then he left with mild TR. So at that time, he was told that it was a mild problem, nothing will happen. So they reassured him and sent him back to home. So again, for the last 5 years, he started having cardiac symptoms, and then they worked him up, and at that time it was found that he's having severe TR with dilated RERV, and he went into early stage of cardiac cirrhosis. So he visited, since then he visited many hospitals for any sort of therapy to that, but of no use. Nobody offered him any therapy. They told we cannot operate on him like that. So his natural course is worsened over a period of time, and his natural course was complicated by recurrent hospitalization with congestive cardiac failure, fluid overload, abdominal distension with episodes of spontaneous bacterial peritonitis. So he is also a known case of hypothyroidism, rheumatoid arthritis, cholelithiasis. He had DVT of left lower limb in the year 2013. He underwent umbilical hernioplasty in the year 2017. In the left panel, you can see a big umbilical hernia there. And this is in the November 2020 when he got admitted with SBP episode. So then in March 2021, when a severe COVID wave was there in India, he had COVID pneumonia. The family was feared about him, and they thought he would not do well. But fortunately, he recovered with home isolation and home treatment. And this time in the month of July, he admitted with severe pain abdomen. Actually, he visited on that day to a other hospital where a famous surgeon is there, cardiac surgeon. He took his appointment. He was waiting there for the investigations. Then he developed severe pain abdomen. So because he was underwent hernioplasty in our center, he came to the same surgical gastroenterologist who did his hernioplasty. And here again, he was diagnosed with spontaneous bacterial peritonitis. On paracentesis, they found that it was a purulent aspirate. So cultures came out. It was a pseudomonas positive. Started him on higher antibiotics. So refer to cardiology in view of heart disease with recurrent hospitalizations and cardiac cirrhosis. So they request us, could we do something for his condition? So on clinical examination, he was in function class 3, pedal edema, huge scrotal swelling, gross ascites. He was not able to move a few steps in the room itself. So on examination, his JVP was elevated, bounding. ECG showed AF with control ventricular rate, right bundle branch block. 2D echo showed grossly dilated RERV, severe low pressure TR, TAPSE of 20 millimeters, myxomatous mitral valve with mild mitral regurgitation, good biventricular functions. You can see the RV sizes are enlarged, and there was a free-flowing tricuspid regurgitation, to and fro regurgitation. So labs LFT grossly deranged with hypoalbuminemia, RFTs were normal, counts were elevated. So at that time, because they requested us to do something, so we discussed in the heart team discussions, but our surgeons turned down it, and they told he's not a suitable candidate for open repair in view of so many comorbids, in view of his hypoalbuminemia, in view of huge ascites, abdominal distension. So we are only left with interventional options, and so we narrowed down on trick valve implantation because of other options are not available or not suitable for him. But because he has a severe infection at that time, so we counsel the family that only after this infection is controlled, then only we can place the trick valve. So we proceeded with the workup, and we have done the CT protocol. We decided about SVC of 29 mm, IVC of 41 mm, and we were waiting for the opportunity. And this is the 3D model. But his condition worsened, and his intra-abdominal infection was worsened. It was full of pus was there in the abdomen with a lot of loculations. Initially, it was managed conservatively by interventional radiologist. So pigtail drainage was done. Both the sides they put the pigtails, and a lot of times they have changed. Almost 15 to 20 times they poked his abdomen. But even then, a drain was continuously coming out. So they suspected bowel perforation. CT abdomen was done, which showed loculated ascites with malrotated cecum with pneumatosis, query appendicular perforation. So then they proceeded with diagnostic laparoscopy, and they have done. They have given a nice peritoneal wash with removing all the loculations, and after that, so here in the picture you can see this is the post diagnostic lab. From the lower wound, still pus was oozing out. So then again ultrasound was done, and they identified that there is again a deep focus of infection in the right iliac fossa. Again they put pigtail in right iliac fossa. Here you can see that pus was draining. So at this time, surgical gastroenterologist and medical gastroenterology team, which he was under them, so they planned for discharge. But then I told, we discussed that if we discharge him with this much of infection, he will not make it. So they transferred the case under me. Then we were waiting. But subsequently, he developed recurrent lower respiratory tract infections and recurrent pleural effusions bilaterally. And our intervention radiologist continuously after that and draining and making him better. But unfortunately, in one day, fine evening, he developed code blue in the room, and which was successfully resuscitated by our emergency medical team. He was in ICU for some days, and they again came back to the room. Then slowly his drain came down and the cultures became negative. So at that point of time, we thought this is the right time to go ahead with the procedure, and we took the necessary approvals. At that time, trick valve was not available in India. It was on compassionate grounds. We had to take special permissions from the government. So then even the money has to be paid directly to the company, which is in the Germany. So family ready to pay the money, and they paid it. So, but unfortunately, while we were planning this procedure, he again went into one more episode of sepsis with septic shock. He was on multiple inotropes, intubated, and he developed AKI during in the ICU. He was on CRRT for about a few weeks. So he had one more episode of cardiac arrest in the ICU. So at this point of the time, everybody in the team lost hope on him, and including me. I thought he will not make it. But after 1 week of CRRT, slowly his urine output started coming, and creatinine was coming down, and then his cultures became negative subsequently. So then our dilemma continued, whether to do the procedure with this background, with this much of with very unfavorable conditions. So majority of the team members who are attending him, consultants, all other consultants, they told we'll not do it. If we do, unnecessarily we are wasting their money, and so they are not keen on him. But when we discussed openly with the family, so the family told that actually this man he's searching for some therapy, and his friends told that, and he googled it. He told that some therapy is available in Kerala, so he want to go in summer to the Kerala to get this treatment done. When I told him this therapy is available available in our center, he was so excited, happy, and he was hoping that he will get it done one day. So with that hope, he tolerated all these procedures. He went through so much of trauma, but still he was hoping to be treated for that. So family told, anyway, we have paid for the wall, and the wall is arrived in India. So why don't you just do it? It was his wish to get it done anyway. So he was like this with the CRRT on ventilator with multiple inotropes with borderline pressures. And then once we decided, we have taken him one fine day for the trick-wall implantation. He was fully ready. We have done the procedure, and this is the SVC wall we are deploying there. We have deployed the walls successfully, and this is the intraoperative TE. Then we have perclosed these are the bicaval implantations. After that, surprisingly, he improved dramatically, and we have extubated him. We made him walk in the ICU, and so he was in ICU. And so our entire staff, ICU staff, are so excited about his recovery. He recovered slowly, and this is the first follow-up after 1 week, and this is the second follow-up. So he is my Iron Man. So he gave me this, and this is the 3 months follow-up. He is doing well now. He is walking around. He's doing well. So whether this procedure, whether it added any days to his life, we don't know. But definitely it added life to his days. He's now doing well. He's enjoying with his family. Thank you very much.
Thank you very much indeed, Dr. Rapolu. That was excellent.
Thank you.
Again, I invite anyone else in the panel, just have you any questions or comments about this? Maybe I'll start. Do you know why he had abdominal sepsis? I didn't see it was clear that it was appendicitis. Was it just general deterioration and illness? He had multiple little bits of infection, or?
Yes, it's SBP because of poor nutritional status and all. So recurrent SBCs because of the lot of populations and all. Probably, I think it was he went into severe sepsis.
Sure. Good job.
Thank you very much.
That was...
Any questions from the panel, Dr. Khanna?
Dr. Gupta?
Yeah, I think I'll just make a comment, Dr. Karunakar. That was a fantastic job and a brave one too. And I think what really helped him was taking care of the congestion which is occurring due to the severe tricuspid regurgitation. And I think that would have caused persistent ascites, sepsis to go on.
Yes, sir.
And once you fix that, I think that is the reason he improved dramatically. I think the job very well done.
Yes, sir. After that, even his abdominal girth, we measured, it was 120, 110 range. So once we put the wall, dramatically abdominal girth came down. So immediately.
Yeah, that would be expected.
Yes.
Yeah.
Thank you, all the panel members.
Dr. Ali Raju, you have a question or a comment?
No, I think it's a great case. He really identified the Iron Man.
Yeah, I mean, it's
very resilient patient who just
so many things happened to him, but still he's so patient. He never got depression. So with all these things, if anybody was in his position, other people, they will get depressed, but he was always calm and cool person.
One interventional comment in patients who are that sick with right-sided failure, I'm not sure if this is available, but RV Impella sometimes helps stabilize these patients.
But he was not in a failure, sir. RV Impella helps in RV failure.
Right.
It's purely because of regurgitation from the TR, not from the RV failure.
Yeah.
We have to stop the leak rather than putting the impeller there.
Good case.
Because, when we saw your echo, it clearly showed that the RV functions were not really down. It was basically the regurgitation going both on the superior side, SVC, and IVC. And probably that was his problem. He was malnourished because of chronic congestion. He had ascites because of that. He had recurrent sepsis because of that. And probably good that he improved and he carried on. And this is probably one of the best results I have seen in trick valves. We have done a few in our country and our places, but I mean, although the recommendation says you should do it before the ascites sets in, but this is one case which actually beats this concept. This is one case which has clearly showed that this works even in chronic congestion and debilitating congestion. Only thing I think what's important is the PA pressure should not be very high, not above 70. And in fact, we had this case presented yesterday also, and the inventor of this trick valve, Dr. Agreli, was giving a oration. He was also very surprised and amused to see results in such chronically sick patients and the trick valves doing so well.
Yes, sir.
Because this is probably one of the only indications of treating, instead of doing a valvular replacement at the valvular level, you are doing it outside the cardiac, outside the heart. So you are putting a part of the valve in the SVC and a part of it in the IVC.
Yes.